Grenier's on his way in. Thank you, Ian. There we go.
He's coming in.
Dr. Grenier is here. Thank you, Dr. Grenier. Merci beaucoup.
It was not easy.
No, it was not easy, and we apologize for that, Doctor. So I'll get it. We'll start off with the introductions, and we'll get things going. Udz, if you would log in, that'd be greatly appreciated. And we'll get this party underway. Dr. Grenier, as I explained to our listeners and people watching on YouTube and on the different pages, we're going to probably have to, and we appreciate if you would accommodate us, extend the amount of time that you're available to us because of this issue. And I apologize most sincerely to you for this. Okay, so let's. I'm gonna get going here. Okay, según sa ugo Robert ariho te batsbil yun just and we're gonna sadagi ti tariha ratinigunare yun charat dako. I want to go so the garide. Good evening, everyone. My name is Robert ariho te batsbil and I'm the spokesperson for your Kanesatake Emergency Response Unit. Thank you very much for showing up. Bonsoir tout le monde. Je m'appelle Rabbi ariho te batsbil. Je suis le porte-parole pour votre unité d'intervention d'urgence de Kanesatake. J'espère que vous allez tous bien. This evening we have with us. A very important person that we will get to in just a moment. The reason that we're doing this is we're having a YouTube live session here on obviously YouTube, on Zoom, on the three Facebook pages of the community. That's First Nations Paramedics, the Kanesatake Health Center, and the Mohawk Council of Kanesatake, as well as it's being simultaneously broadcast over RKR 101.7 FM, reviving Kanesatake Radio. What we're going to be doing tonight is we're going to be getting to your questions. You can also give us a call at 438-686-4335. That's 438-686-4335. We're going to go around the room. We're going to let you know who's here. Obviously, everybody knows me. I've introduced myself. We have Joyce Bonsfield-Nelson, the Executive Director of the Kanesatake Health Center. So thank you very much, Joyce. Joyce is going to be one of the people asking questions to Dr. Grenier tonight. We've received a lot of questions. There we go. We got Udzi coming in, our Grand Chief, as well as Madame Thériault. Madame Marie-Ève Thériault is the assistant to Dr. Grenier. So merci beaucoup d'être venu, Madame Thériault. You guys, you know how the procedure usually works. Usually I do everything then we do it in English, then we do it in French. It's going to be a little bit different tonight. We're going to go back and forth. We're going to mix it up. So a lot of people are going to, if you don't understand all three languages, I apologize. But we will get to your language. So without further ado, again, we have Udzi down below, our Grand Chief. Thank you very much. Now go Udzi for being here this evening. Udzi will be asking some of the questions as well to Dr. Grenier. And finally, we have Dr. Jean-Luc Grenier. Dr. Jean-Luc Grenier is with the Public Health Authority in the Laurentians, and I'll allow him to introduce himself and to give us a presentation that will last approximately. The presentation is approximately 25 minutes. So Dr. Grenier will go through that. So thank you very much, Dr. Grenier. C'est à vous. It is your turn, sir.
Oh yes, thank you. Hi everybody. So I'm a public health physician for over 30 years. I was responsible of the immunization programs in the Laurentian area. So that's why your people asked me to come here tonight to talk to you about the vaccines. And I know that there are many questions. That's it. I prepared for you a PowerPoint presentation, and after that, I will be open to answer every question. So can you project the PowerPoint? Or do you want me to try to share my screen?
We're just looking at that right now. We're trying to fix it up. Again, a little bug.
I can try to share my own screen if you want.
Dr. Grenier, you're going to be able to share your own screen in about 30 seconds. So we apologize for that.
I try that. Oh, I'm disabled. The host disabled participants to screen sharing. So you should try to make me available for screen sharing, if you can.
I think we have it fixed, Dr. Grenier.
Oh, okay, you get my presentation. So we'll go on the second slide. So we'll talk about, this one. We'll talk about the burden of the disease, the goals of the immunization campaign, what are the vaccines that we get now, how they are developed and approved, how they work. We'll talk about who we should vaccinate in priority, what are the precautions and contraindication and so on for the vaccine, what is the schedule of the vaccine, if it's effective, and APHIS, that's adverse events following immunization. Many questions about that. We'll talk about myths and facts and then answer to your questions as much as I can. Next. So we see here a picture of the Spanish flu in 1917 when during the First World War, there was a new pandemic that killed almost 3 times more people than the war itself. So we are now in a remake of this kind of situation. But that's life, you know. Okay, next. So we hear a lot, and a lot of time we hear people say, well, that's just a flu. But look at this picture quite honestly. The little red dots, the straight line at the bottom, is the average deaths per week in an average year, okay? The full red line is the number of COVID cases, and the blue line is the over mortality above the red spotted line. So we quite are able to see that this COVID disease is causing a huge over mortality. So yes, there are people dying from cancer, dying from car accidents, etc., dying from flu also, but there is a clear over mortality caused by COVID, and that dotted line, you know, includes every other causes of mortality that I talked to you. So the burden of the disease is quite real. Next. And here we see, here in Quebec, the curve of the hospitalization. Look at the number just at the left side. We were up to 500 hospitalization per day just recently in January. That's quite a huge number of people over the normal number of people that are hospitalized. And that's why we're talking always in the media, we have to spare the hospitals, we have to spare the health system. And at the bottom, we see the number of people at the intensive care. So those people are very, very sick. They need intensive care beds. And they, contrary, for example, with a flu case that may get to the intensive care, those COVID people would stay there instead of 2 to 4 days. They stay there for 3 weeks. That's a huge, heavy burden on the health system. Next one. And at the top, you see a pie, which is the percent of age groups that are affected by COVID. And we see that it's about even, you know, young people, mid people, old people. But at the bottom, we see the age burden of the diseased, okay, and the deaths. We can see that the dark parts are the old people. We all know that, but the old people are very, very at risk to die from the COVID. But there are also young people that die from the COVID, much less in person, but there are some. And there are also, which is not illustrated, many, many people that continue to get, after they have their acute phase of the COVID, they still get a long time of fatigue and all kind of disabling symptoms that are very unpleasant and on the long term. Not 100% of the cases, but quite a lot. And now, next diapo. we have those new strains, which up to now that we know are not more grave, more morbid. They don't get you more sick, but they are much more contagious. So if you have a more contagious virus, you have more problem to stop it. So that's the problem with the COVID up to now. So what can we do and what do we do? This is a very important scheme to understand quickly. To stop an infectious disease, we have to understand the transmission chain. Okay, and at the top you see the source from you start with a sick person, which is the source for the COVID, the virus. To get to another person, the virus has to have a route. Okay, in the case of the COVID, it's air droplets. If we're talking about AIDS, it's a sexual relation, or exchanging of syringes. But in the case of COVID, it's throwing your air droplets, and while you sing, while you talk, when you breathe, and then you get an entrance in the other person, which is the airway in the case of the COVID. The other person breathes and gets the virus particles in her own airways, okay? And there is a quantity. If you have just 2 viruses in your lungs, you won't get sick. If you have 30 millions, you will get sick, okay? And at last, you have the susceptibility. If you never met this virus, you are susceptible. If you are vaccinated, you have antibodies and you're not susceptible. And that's where we are working with the immunization program. We are breaking the number of people that are susceptible. Vaccinated people, by hope, if with an ideal vaccine, they would be 100% protected, we would stop the transmission of the disease. But look at the other arrows. That's why we put a mask, okay? Because we want to stop the root, and we wash our hands because we want to stop the quantity. If we touch somebody that is contaminated and we put our hand in our face, if we have washed our hand, we stop the quantity of virus. But when we have diseases that are airborne, like this disease, it's always the best way to stop the transmission, because we cannot stop breathing, okay? It's an airborne. We have to breathe and we have to talk. The best way is to stop the susceptibility, vaccination. Okay, next one. So the goal of the vaccination campaign is to provide vaccination to everybody. Ideally, we vaccinate everybody because we want to stop this disease. So just for remembering, in the 2009, we had the H1N1 flu pandemic, and we succeeded in 3 months to vaccinate 4.2 million people in Quebec. That was very good. But the problem with this vaccine, one of the problems, is that as far as possible, we need 2 doses. That's a double burden of work, okay? And the objective is to reduce mortality, so if we protect people, they won't die. Reduce the number of hospitalization of diseased people, and to be able that the healthcare would be capable of caring for the other diseases that are still present. Okay, this is not because we have COVID that we don't have to do surgery and cancer treatment and everything. So now we have to postpone everything because of this COVID. And so we also want to reduce the impact on society, because now, in order to break this transmission chain, we have to stop everything because of the transmission chain I showed you. If we stop to be susceptible, we stop to need all those measures. So no susceptible means no COVID-19 and no measure of public health distanciation and everything that we are very tired of. Next one. So those vaccines, what are the steps of vaccine production? It's a very long process. We have first to know the bug. We have to find a way to comprehend it, to do something with it. The first vaccine were very easy to do. They were growing a bug, killing it, and putting it in your arm. Very easy. Okay, that were the first vaccine. The easy one are all done, and the new vaccine are a little more difficult to do, to fabricate. But from 20 years already, the kind of vaccine that we're talking about, the mRNA vaccine, were on the pipeline already. Okay, so when in January 2020, the genetic code of the virus was already published by the Chinese experts, already the RNA vaccines were already in the pipeline to be managed. So what was done is a quick overlap of the, what you see here is a one by one step. What we did was to overlap the steps. Okay, we are trying it on the phase 1 study, but as soon as the phase 1 study is starting to look good, we start with this vaccine, this phase 2. And as soon as the phase 2 starts to look good, even if it's not over, we start the phase 3. And all together at the same time, the producer were confident in their vaccine, so they started the production as soon as the beginning. That's not the usual way to do, but it's the exact same way, but with overlap on the steps. Okay, next one. In fact, there was no step that was not done. It was just an accelerated approval process. And because of this unique event and very emergent situation, everybody in the world was collaborating. Contrarily on, for instance, in the flu vaccine, there are competition between the companies and they do not tell one another their secrets processing, you know. But now this was very different. At the very beginning, everybody was sharing the genetic code of the virus, etc. Next. So we see here a maquette of the vaccine, which, of the virus. Viruses are very simple beings, just a little capsule with some RNA inside, which is the code of the virus, okay? And some legs, the little spikes are the legs of the virus. And those legs are used by the virus just to stick on our cells in the nose, in the throat. And when those legs stick on our cells, the genetic material of the virus gets inside our cell and starts replicating the virus. Our cell becomes a virus fabric tool. And after a while, the cell explodes and liberates in its environment thousands of viruses which are sneezed away and get to other people, you know. So what are the RNA vaccines? It's just you take a little bit, the little bit of this RNA of the virus, that code for the legs, and you put it in a little tiny drop of oil, just that. This is not a virus, what you see on the right. It's just a microscopic tiny drop of oil in which there is a little bit of the code, genetic code of the virus, the part that code for the legs, the spikes. And okay, next slide. When you put this, that's the vaccine, okay? When you inject those little tiny lipid drops, lipid means grease, this lipid is needed to come to the membrane of the cell. The envelope of our human cells are lipid done. So when the lipid touch the lipid, exactly as a bubble of soap coming on, for instance, on a lake, which the bubble would merge with the lake. Okay, so the lipid of the tiny drop merge with the cell, and the RNA that is in the drop gets into the cell. So this little drop of oil is just a way to go to let inside the cell the little bit of RNA. What is it, an RNA? It's messenger RNA, okay? What does it mean? It's a letter. It's just a letter in which it's written, so now you have to build that. And this is the code of the spike of the virus. So the cell that gets this little RNA code starts to listen to the code, and in the fabric of the cell, it starts to fabricate spikes of the virus, and we see the expression, as we see, of the spike at the surface of the cell. And then those spikes become apparent in our body, and our immune system recognizes those spikes as being stranger and builds an immune response as usual as it does against any normal virus or any normal pathogen that we meet. Our immune system builds and answer antibodies that are the dark blue things above the spike at right. This represents an antibody that is secreted by our immune system. So when you got this immune response, if you ever meet the real virus, you will right now block it before even it gets in your cells. Next slide. Okay, that's the same. That's the text about what I've just explained to you. So we have a lot of vaccines that are already pre-ordered by Canada, and we know now that we have already in our fridge 2 of them. Well, we don't have any more for next week. But the first was a Pfizer messenger RNA vaccine, and we had also Moderna vaccine. And very soon in blue, we have probably in a couple of weeks, we'll have the homologation of Johnson & Johnson vaccine, which is interesting because this vaccine is just one shot, one dose, okay? And there are others that maybe will be homolog. So the more we have, the best it is. Of course, we want those vaccines to be efficient. Okay, next slide. So when they did the clinical trials, they want to know if the vaccine is effective. And we look that the mRNA, the two are almost the same. 14 days after the first dose, the vaccines show an efficacy of 92%. That's quite good, very good. Over 90% is among the best vaccines that we have. You know, the usual flu vaccine every year is on average 60% efficient, which is better than nothing, of course. But 92% is very good. That just with one dose after 14 days. And 7 days after the second dose, we have 95%. You will see in the papers that duration of protection is unknown. Take care. Unknown does not mean that it's short. It's just unknown because the vaccine is new, but it's probably very long because if we look at the curves of the immune response, it is very similar to many other kind of vaccines which give a protection for 10 and to 20 years, okay? So in my eyes, I cannot tell you that the protection is long. We don't yet know, but it looks that it will be long, okay? Next slide. So we have the problem of operational coordination with the problem of the Pfizer vaccine, which must be freeze at -80. That's a lot of problem because, you know, your average freezer is -10, -15. So we need special freezers. So the federal government manage all those logistic problems, and they give us they buy the vaccines. They send us the vaccine. They send us the syringes and many material, and the provinces are responsible of protecting the health workers. Okay, next slide. So who should receive the vaccine? as I told you, the ultimate objective is to protect everybody, but we don't have a vaccine right now for everybody, and we have to start somewhere. So we start with the most frail people, so the CHSLD residents, and also the most important people to keep the system working, the health system working, the workers who are in contact or who give care to all those users and in the hospital and everything. So the frailest, the health worker, and then a little less frail, but the elderly residences, old people. And point 4 is isolated and remote communities. And at large, they put the like your community, because not because they are remote, but on the many of the autochtone population are remote. So I think that the federal government did not mind to, even if you're in Kanesatake, you are not remote, but you are autochtone community. So you are in the melting pot of the remote communities. And then you go with age, okay, the oldest being the first because they are the most important to protect. And then we go down to 60, under 60 who have chronic illnesses, because if you have, for instance, diabetes, you're more prone to die from COVID or to have complications. And then you go to the last to vaccinate all the children, because, as you know, the kids do not get almost never complications, okay? And the last is pregnant women, because we don't study usually medications or vaccines on pregnant women because by precautionary measures. But if you ask me, I am a health worker, I work in a red zone, I am pregnant, yes, you should be vaccinated. It's not a live vaccine. There's no danger with this vaccine. You are in danger of getting the COVID, you should be vaccinated. Okay, it's not a contraindication to be vaccinated when you're pregnant. So that's what I said for the pregnancy. Breastfeeding, you could be vaccinated. Autoimmune or degenerative diseases, yes, you should be vaccinated, because probably if you get the COVID, you would be more prone to have complication or die. So yes, you should be vaccinated. Immunodepressed, yes, unfortunately, the vaccine may be less effective because your immune system is maybe low, but you are at very high risk to die from this disease. So yes, you should be vaccinated. And maybe if you get the disease, you should be protected to have it less strong. And for now, we don't vaccinate the children. We have very little data. They are not at risk to complications from the COVID, so they are the very last on the list. Who should not be vaccinated at all? Well, contraindication in medical language, the only one is anaphylaxis. If you did a severe allergy with a previous dose of this vaccine or another constituent of the vaccine, but remember what there is in the vaccine I showed you. It's just a little drop of oil with RNA of the virus, and that's it. The other components are not allergenic components. They are salt, sugar, water, just to hold those many little droplets. So very rare people could pretend beforehand to be allergic to this vaccine. But there is polyethylene glycol like constituent in the oil drop. So if somebody would be anaphylactic allergy to laxative, which is polyethylene glycol, we would not vaccinate this person, okay? This is the allergy contraindication. So no contraindication to vaccinate a person who has allergic reaction who are not related to this vaccine or the constituent. Because we read some people saying or papers saying Oh, if you are the kind of people who have many little kind of allergies, or you carry an EpiPen, oh, you should not be vaccinated. Not at all. There are thousands of people that have many kind of allergies, and we would we already have vaccinated millions of people in US, and those people do not have problem receiving the vaccine. Next. So what should you, maybe you heard about the fact that when we started the vaccination here in Quebec, we started in a CHSLD, which was in eclosion. There were many active cases. And after vaccination, there were vaccinated people that got the disease, and people started to say, hey, what? That's not a good vaccine. But you have to understand that when you get the virus, the incubation is about 6 days in average, and maybe up to 14 days. Okay, it's from 1 day to 14 days. Okay, if you get vaccinated on day 2, 2 days ago you met the virus and you get contaminated. You don't know. You get the vaccine. 10 days after the vaccine, you could get your disease that you catch before the vaccine. This is not abnormal. This is a situation when you vaccinate many people in an eclosion situation. It's normal that some of them already had caught the disease, okay? And the immune response, the response to the vaccine, to this vaccine, and to any vaccine, the response does not depend on the vaccine. It's our immune system is like that. It takes 14 days to get the first antibodies, any vaccine. So when you get vaccinated, it's not immediate protection. It takes 2 weeks to get protected. Okay, next. So the schedule of the vaccine that was studied by the companies is 2 doses, about 1 month apart, 3 to 4 weeks apart. But the scientific committee in Quebec and elsewhere in the world also decided, OMS decided also, that it's better to give the first dose to the greatest number of people. You saw the first dose is 92% efficient. That's quite huge efficacy. So it's better to protect many people and stop the circulation of the disease than going after the same people a second time 3 or 4 weeks after and letting susceptible people on the side. Okay, so that's the way we decided. And the second dose is required for the longer term protection. So the next slide explain that a little more. This is the typical immune reaction after a first dose. You have the rise in antibodies that doesn't start before 10th day, okay? And maybe after a month or so, it would fade out. Then if you take a blood test, you'll see the antibodies going down. But this does not mean that the person becomes susceptible again, because there is an immune memory that we call anamnestic response. And the second dose is just grabbing this anamnestic response. Look at the curve. After the second dose, the rise of antibodies is much sooner, quicker, higher, okay, faster and higher and longer. This is the booster effect, okay? In medical, we say anamnestic response. But if you don't have your second dose, if instead of the second dose is the real virus that comes in your kid comes back from the school and he's got COVID, is contagious, and you don't get the second dose, you get the COVID, okay? The COVID virus that gets into your body. Your anamnestic response will break out the same as the second dose of vaccine. So you won't get the disease, you will just boost your immune response, okay? So that's why we are very confident. And look at the black sentence. This is a basic principle that I teach for many years before, not because of the COVID. An interrupted sequence of vaccination. That means interrupted means that your second dose is not given at the predicted 1 month apart. you interrupt, you forgot to come to your meeting, and two years later, oh, my second dose, what's up? So the sequence was interrupted. What should we do? Do we have to start over? No, the memory, immune memory is there. You just have to give the second dose and the boost will be there. So you don't have to restart all over. You just give the second dose. And that's why delaying the second dose is never something of a worry, never. And even for some vaccine, when you give the second dose later, the boost is stronger. So that's an important point. Okay, next. So what's coming up after the immunization? Do you get the disease? Of course not, because this is not a live vaccine. It's just a little bit of RNA that is coding for the legs, not for the virus. So what do we see after the vaccine? Mainly, I will show you another slide later, but mainly it's pain in the arm, okay? So I just go out with this one. It's too small, too small writing. Next one. Okay, look at what we see. In most cases, more than 50% of people, pain at the injection site. Very often, but less than half of the people, headache, fatigue, okay, fever, joint pain, aches, sometimes diarrhea, vomiting, or you have a kind of lymph node on the side which you were vaccinated. Often, but less than 10%, redness, swelling at the injection site, which is not just pain, but clinical observable redness. And very rarely, but we see that, a little facial swelling, little edema in the face, like your lip will become a little swelling, okay? And the little sentence down, approximately 4% in 100,000 can have allergic reaction, which is more than usual vaccines. Usual vaccine would be 1 person per million would have anaphylaxis, that when you need to give adrenaline. With the Pfizer vaccine, we see in Quebec, up to now, 4% per 100,000, which is not so much, but it's a little higher than what we wait, what you're used to. So what we did to this with a new vaccine, usually we have passing monitoring for the side effect of vaccine. Every vaccinator, doctor, nurse, if they see a potential, something that they think is a side effect of a vaccine, any vaccine, even if not them that they vaccinated the person, the law required them to declare, okay, this is what we call a passive system. We're waiting to see if doctors would give us a call and say, hey, maybe this person maybe have a side effect. But now with a new vaccine, we are proactive. What we did since January, since we started to vaccinate the healthcare workers, we have a sample of them and we call them 1 week after and we ask them, every one of them which are randomly selected, we call them and we ask, did you have something after your vaccine? So let's look at that. So up to now, we called 10,000 people, okay? And 6,000 responded. This is in French, sorry, but I just give you the number. So we have about 60% response, okay? Many of them are women, but many of the workers are women, so it's just a representation of the people which are vaccinated. So let's look at the side effects that the people told us. Next slide. Look at the first column, okay? Total 6,000 person. The other rows are ladies, man, age, but the first column is the total. About 70, like 2 out of 3 said that they had pain or redness at the site. That's quite normal, okay? I sometimes say to the people when they talk about their pain, oh, you're lucky because it shows that your immune system is working against this vaccine, you're responding to the vaccine. Good, okay? But of course, better not to have pain, but. And look at the rest, 2% systemic problem. Systemic problem is like all your body is fever, for instance, or I feel aches. That's systemic problem. Neurologic problem are tinglings, okay, like picotement in French. What tinglings? Engourdissement. Sorry for my tinglings. After that, respiratory problems. Some people said that they coughed. There was zero anaphylaxis. Okay. Next slide. So you see that mainly it's a local pain. After that, 2% have had to arrêt des activités, mean they could not go to work. Okay, they had to stop what they usually do. 2%. Okay, and 24, that's 0.4%, went to see the doctor or called Info Santé. And one person was hospitalized for overnight because this person had a big reaction on the shoulder, and the doctor just wanted to see if it was maybe an infection, but it was going down the next day, and okay, you can go home. Okay. Among those 6,000 people, 200 had antecedents of COVID, so they were vaccinated even if they had COVID maybe in spring, you know. Which is a question I saw, should we get the vaccine if we did have the COVID? The answer is you should not, you do not need to have the vaccine in the first 3 months because we know that the disease gives you immunity for at least 3 months. But after 3 months, it's better to get vaccinated. Okay, next. So important information, the vaccines are free for everyone, and there are no vaccine available on the private market. So take care if you have a phone of somebody who wants to sell you a vaccine, that's a fraud, okay? And you're not obliged to be vaccinated. It's a free vaccine and free will to get vaccinated. So, but the vaccine is strongly recommended. We want everybody to get vaccinated because, or at least as much people as we can to be vaccinated because we want to stop the transmission of this disease. So in your spot in Kanesatake, not before March 15, as much as I know, but I think you saw in the news that it's always on and off, and I cannot predict the future now. So the authorities will be in contact with your managers, and as soon as the vaccine will be available for Kanesatake, they will be available. So this the organization things are not on my spot. Next. So we did some surveys to know if people want the vaccine or not. And on average, we see that about 3/4 of the people want the vaccine. And if you ask the healthcare people, 100% of, I exaggerate, but because they saw the workers in the healthcare system, they saw the cases, the difficulty of breathing the diseased people. When the healthcare people have seen the COVID, they want the vaccine. But in the average people that did not see the cases, 25% are hesitant. And it's understandable because we read some things on Facebook. We hear that, it's Bill Gates that want to put some chips in our blood. But so I will answer all those questions later. And since it's not mandatory vaccination, we estimate that approximately 10% will refuse the vaccine. So it's free. It's up to you. So the myths, just as a bad flu, as I told you at the beginning, this disease is much more severe. And another point that I didn't tell you, think about it. We blocked the transmission as much as we could. No going out, masks, distanciation, wash your hands. We stopped the economy. And even with that, and this was efficient to stop the flu. The real flu, I don't know if you realize, but starting in March, when we stopped everything, the flu dropped to zero. There was absolutely no respiratory viruses, flu, syncytial virus, upper respiratory coughing, all were out. But this COVID virus is so contagious that even with that, is still circulating because we don't have this average immunity that this virus never was met before by our immune system. And that's why we need to immunize as much people to stop that. So another myth is vaccines were made too quickly. Yes, they were made quickly, but it was respecting every scientific standard. And you cannot get COVID from the vaccine. That's not true. It's not a live vaccine. And vaccine could change your DNA, your genetics. Not at all. The vaccine is not a DNA vaccine. It doesn't get in your nucleus of your cell, where is your genetic code, your DNA. It's just a messenger. It's just a little letter that comes in the periphery of your cell, just telling the little fabrication shop to build this virus spike. And as soon as the letter is read, it's destroyed, and it goes in the garbage. So this RNA, messenger RNA, does not last long in your body. It lasts maybe a couple of hours, and your cells start for a little time to excrete those viral spike, and you build your immune response, but there is no anymore RNA in your body. Vaccine can cause infertility. There is no ground for that. COVID, the disease, gives you long-term immunity. It doesn't look like that because we start to have people that did get the COVID in March that are getting it again. So this not so much people, but enough people to tell you that you don't have a strong immunity after the COVID, the disease. Vaccination will exempt you from the measure, the social distanciation, the mask. Well, yes, but just in the long term. You cannot say, okay, I'm vaccinated, so tomorrow I don't put my mask. I go to do what I want to do anytime I want to do because I'm vaccinated. This is not the case because first, you for yourself may be in the, unfortunately, that about 10% of persons that do not respond to the vaccine, okay? And moreover, we have to wait until the circulation of the virus is down. So we must wait to have enough people vaccinated. And the measure are on a public health scale. So when we will see the mortality and hospitalization going down, then for everybody, not just for the vaccinated people, for everybody, we will slack on the measures, okay? Severe reactions are very frequent, not at all. We saw the statistics, which are very frequent is pain on the immunization site. And microchips or tracking devices, well, the best microchip you have is your cell phone. You know, you don't need a vaccine to be tracked. The tracking is your cell phone, not the vaccine. Okay, next slide. So I hope you understand those communication issues. And the last one is the most important, the contradictory messages with the social media that will tell you, don't do this, don't do that, I saw this, I saw that. You always have to try to find reliable media to take your decision. Next slide. So we have an historic challenge with this disease. We have to control, and as I showed you with the transmission circle, stopping the susceptibility to most of the people is the best way with those aerial transmission. And we want to return to normal activities. The sooner, the better. So now I think, up to the question period.
Thank you very much, Dr. Grenier.
Sorry to have been so long.
Not at all, Doctor. It was very informative. Thank you very much. And you've gotten a lot of the questions that we had prepared for you off the papers.
Yeah.
So thank you very much for that. We have a couple of questions. Almost all of our questions came from community members. Some of them would like to know, and that's what we're going to go through. So we're going to take a turn. I'm going to give you a question, then it'll be Mrs. Bonspiel Nelson, and then Grand Chief Simon, who will be asking the next questions. So the first question comes from one of our listeners on RKR radio, 101.7 FM. The question is, if a person is over 50 years of age and healthy, do you consider that, do they need the vaccine?
Well, as I told at the beginning, we want to vaccinate everybody, and everybody, I think, should want to be immunized just in order not to contribute to the transmission. Of course, the younger you are, the less you are prone to have severe disease, to get hospitalized, and to get complication. This is not impossible, however. And if you get the disease, you transmit it, and you are a burden for the society, okay? So the younger you are, the less you are susceptible for complication, but you may be a transmitter. So there is no reason whatsoever not to be vaccinated when you think about it, because even if you get the disease, you could get it very severe. There is one of my friends, 35, he's dead of COVID. 35, good health, but he died. One of the rare of this age, but this is a possibility.
Thank you very much, Dr. Grenier. We have a question now from Grand Chief Udzi Simon.
Yeah.
Okay, you got to mute. Here's one question. My spouse had COVID and we quarantined in the same house and they never got it. In your opinion, did we do something right?
You mean the person, the wife had the COVID, and then the other didn't have probably the COVID, but did they get tested? Probably they got it very slightly asymptomatic, or maybe the wife was so well protected because maybe they did very strict. She's on the bedroom and nobody go in the bedroom, and they put mask and wash their hands. Maybe they didn't get it, but I don't know. You know, nobody will ever know if they don't get tested. Maybe they did get it asymptomatic. There is about 10 to 20% of the people that get the virus, they develop it asymptomatically. No clue at all that they get it.
Thank you very much, Dr. Grenier. Thank you. If we could get a question from, sorry about that. We're going to get a question from Mrs. Bonspiel Nelson. Please, Joyce.
What the long-term side effects that COVID can leave you with besides death? I know of some people that are.
Yeah, you mean some long time effect of the disease?
Yes.
Yeah, we have many people that, not so many, but those who have long time effects. You have the most important is long-term fatigue, okay, tiredness. And there is also vascular problems that we don't really understand. But for instance, my friend that died was with hemorrhages in the brain. Okay, the COVID seems to, in some person, not everybody, but they get clotting problems and joint problems also. So there's a long list, but I don't know by heart the percent of which is the most frequent or not. Sorry.
Thank you very much, Dr. Grenier. Another question here. Is it possible for someone to be naturally immune to COVID?
Well, naturally beforehand, no. But if you get the COVID and you are very little sick and you get your immune response, then you are immunized. But beforehand, before March 2020, nobody had not at all any immunity against COVID. Does not exist. And another side question about that. If you are healthy, you eat well, you do sports, and you eat your vitamins, and you okay, this does not give you immunity against COVID because you never met COVID before. And this does not guarantee you that you don't get to the hospital, because it depends so only on the relation on this virus and your immune system. You could be full health, and this interaction of this virus with your immune system, your genetic code will manage in the bad way, and you get to the hospital and you die, even if you're 30 years. We don't know who will get to the hospital, you know. Unpredictable. Sorry.
Thank you. Oji?
Just going through the list of questions, trying to determine which ones were answered by your presentation here. There's some still valid questions out there. Like, how about we re-explain this? What is a false positive or a false negative?
Oh, very interesting question. When you test for the COVID or for anything, for any test, you know, let me give you an example. If we go back in December 2019, okay, just before the COVID, and we test with the actual test, the PCR test, we test 100,000 people. They are all negative, you know. Nobody in this one, so much people is COVID positive. But even if they are all without virus, there will be a few that will pop up positive, because a test is never perfect. Our test is 99% sensible and 99% you are also false negative. So a false positive is a test that says, yes, this person is positive, but in fact, in reality, this person doesn't have the COVID. This is a false positive. And inversely, there could be a false negative. I have the COVID, I do a test, and the test says, no COVID in that guy. This is a false negative, okay? But the tests that we use actually there are very few false results. But it may happen.
Thank you. Joyce?
Okay. So if I'm cleaning in my house and we're all washing our hands and wearing our masks and everything, how do we know whether or not we're cleaning everything, you know, without having to, you know?
Well, you know, the cleaning in the house has not to do a difference with when you clean your house. Usually, you're okay. Okay, and what are the good practices? Not just for COVID, for always. You clean the high touch surfaces. Okay, with any soap or usual commercial soap, your counter, your fridge, you know, all the handles where the high touch surfaces are the places where you could touch a surface that was contaminated by another person. Okay, you don't have to disinfect the floor. You won't go to lick the floor, so you will never be contaminated by your floor. You have to be concerned with the high touch surfaces. But let me remind you that the COVID in my transmission chain is not transmitted mainly by things. It's transmitted by person directly with talking, with breathing the breath of the other person. That's the main 99% of the transmission, not the object. So, you know, at the beginning, we didn't know everything. So we saw people that when you get your grocery, you wash even the food itself. No need to do that. And the COVID is killed by the cooking is killing the COVID, and the surface of the thing is not the main way to transmit the COVID. And we wash our hands. That's it.
Well, you just answered about 2 or 3 questions that were already in here. So
Yeah.
with your answer, thank you.
Thank you.
Thank you very much, Dr. Grenier. We have a question here from the Facebook. Usually we're not going through the Facebook. If you could, please, in the future, just try and go through the YouTube live. But I'll read it as is, and I won't put your name out there because I didn't get permission for that. My father is 86 years of age. He contracted the virus from his CHSLD in May. 9 months later, we find his dementia has accelerated and gotten much worse. Is there a correlation between the neurological effect the virus would have had on him, or is it just the natural progression of his dementia?
I cannot give an answer to that. I don't know his case personally, and both answers could be true, but probably the condition was on her own. This is the natural history, you know, of this condition, even without the COVID. But for specific case, I'm not able to give an answer.
Okay, thank you very much, Dr. Grenier. Udzi, if you would.
I have this is a pretty, I guess, plain question, but I think just as important that people should understand. Lysol is hard to find and expensive. Is there another less expensive way to clean?
Okay, yes, as I said a few minutes ago, any cleaning stuff is good. You know, viruses are not well-being in a cleaning environment. They don't like to be washed with anything.
All right, thank you very much. I just want to remind, sorry about that, we'll fix that.
Whoops.
I just want to remind everybody, you can call 438-686-4335. That's 438-686-4335 to reach RKR 101.7 FM, and they're forwarding their questions to us. So thank you very much for that. We're going to go to a question from Joyce. Joyce, would you please?
Yes. How can I protect someone in my home who has a respiratory issue like COPD?
Okay, you mean you have a person which has a chronic pulmonary problem?
Yes.
First of all, don't get COVID in your house. So you respect all the recommended measures, and then you won't get COVID, and you protect your body. But unfortunately, if you get, for instance, you're this person's wife, and you get COVID at your work, you're a healthcare worker, it's better to separate it, to be very strict enforcement of this hand washing, mask. You don't want to transmit this virus by respecting all those instructions that you already know. But unfortunately, it's very contagious, so you may fail and your person will get it. And unfortunately, this person could more risky to get complications. So the first is don't get it.
Don't get it.
Bring it in the house.
Okay, thank you.
Thank you, Doctor. We have, I'm going to combine a question here. We're going to change speeds. We're going to start to talk about the clinic after this one. Again, I want to remind everybody you can get in touch with us here at 438-686-4335. Give them a call and we can get that question to Dr. Grenier. Thank you again for your time, Dr. Grenier. The question we have is an interesting one. Is it possible to get either the flu and COVID at the same time, and or COVID and a different strain at the same time?
Well, to get flu and COVID is possible, theoretically, but as I told you, we are so strict now in our breaking of transmission chain that the flu is dead now because it was not adapted to such tight measures. But it could, if you would have somebody which has flu and at the same time somebody who has COVID, you could get the both viruses at the same time. It's possible. And what was the second question?
The second part of the question was
two strains of the same virus. Well, less possible, much less possible. You would be very unlucky.
Thank you very much, Doctor. We're going to start with the questions now in regards to the clinic. We've got a lot of questions in that regard. Joyce, if you would, please. Oh, sorry, I meant Udi. I'm sorry, I'm mixing people up here. Grand Chief Serge Simon, would you please?
Okay, I know there's a lot of questions on the priority of employees, like status of individuals in our community.
Mm-hmm.
But we'll start with the vaccination here. The vaccination, we were explained by Dr. Grenier that we should be getting the first vaccines in our community. I'm not exactly sure on the amount of vaccines we'll get, but I'd like to get the entire community vaccinated if possible. This should be about the second week. I believe it's really said March 14th, right? Or 15th. That's right. So the health center is going to coordinate the effort. We're looking at having hot room, cold room. We're looking at possibly even like drive-through. So some of the details were discussed at the ERU. I think Bobby can have more detail on it.
Oh, sorry, I did not understand the last thing.
The coordination for the building we're going to use. Oh, that was a question for Robert Lonsville. Okay.
Sorry about that, guys. We're going to get right to it. We're just looking because we mixed up our notes. We apologize. We were going to be talking about the vaccination clinic and how it's going to work and how it's going to come together. And the Grand Chief was indicating that from our first reports, we're going to be receiving the first vaccine approximately mid-March. I know that you wouldn't be able to give us an approximate date on whether or not or when we're going to be getting the second shot, because a lot of people are saying that there's a possibility that we won't receive it.
I don't think that you won't receive the second dose. Of course, you will have the second dose. When is another point, but you know, as I told you, to postpone it a little is not so much of a problem.
Okay, thank you, Doctor.
Okay.
Sorry, go ahead, Joyce. Sorry, I have a little technical problem.
That's okay. I had a question that I didn't see on the paper, and now I can't remember what it was. So I should have written it down the same way I normally do. Okay. I'm sorry. Somebody else go ahead of me.
I read one
Sorry,
of
guys,
the papers that you sent us. Will I take the vaccine, me as a Dr. Grenier, and would I let my mother take it? Of course, yes.
Yes.
Of course, yes.
All right, thank you very much, Doc. Let's see. Who will be included in the classification as frontline or essential workers? Has it been established by the province who is considered a frontline or an essential worker?
Well, you know, every worker that is in close contact with the care, people we care, people in the hospitals or in the health centers, or the oldest people. So healthcare workers that are in contact. If you are the manager in your room, you know, you're not a healthcare person, even if you work for the hospital.
At the back of the line.
So we want to protect first the people which are in close contact with the beneficiaries. But, you know, at the end of the day, you have the vaccination clinic, you have 2 doses left, and all the people that you have targeted are done, and you have 2 administrators of your, give it to them, and instead of losing the doses, okay? But this is just a logical way. So the best you can, you respect the priorities, okay? You have to start somewhere and end somewhere else. You cannot vaccinate everybody at the same time. So but you could mix a little according to the circumstances.
So a natural caregiver, for instance, somebody who's taking care of an elderly, sick mother, that person would be considered
well,
priority?
in your organization, those people should come after the healthcare workers, okay? But before somebody that works in the community, you see? It's logical, it's just logical.
First.
Yeah.
Joyce, go ahead.
Before Bobby. Okay. Will our healthcare workers and our private residents be vaccinated prior to the community being vaccinated, or is it all going to be at the same time?
I'm not sure to understand your question.
So we have our nurses,
nursing home,
nurses, and you know, others have direct contact with the elders, and also our private residents.
Okay.
And the workers that are there. Will they get, because you're looking at your first, second, and third priority, and it's private residence is in there. Will our Riverside Elders Home get vaccinated along with the other private residents, or will we have to wait until the 15th of March? Because I'm just thinking of the nurses are getting vaccinated, the healthcare workers getting vaccinated at the same time that they're having to do the vaccines, you know, and their arm is sore, or they're tired, or, you know, having some of those symptoms. That gives us less workers to be able to give the vaccine when we're doing the whole community.
Yeah, but as I saw in the CHSLD that we did vaccinate at the same time the workers. Okay. Yes, there are a few workers that did not go to work the day after, but you saw the percentages. It was a very small, like 2%, even less than 2% missed work. So okay. It's not a bother.
It's not a big deal.
Not a big deal.
Okay, so
they will go to work. They won't find this excuse to have a day off.
They won't be getting vaccinated prior to the 15th.
The workers or the
workers, the workers and our Elders Home, Riverside Elders Home, they'll get vaccinated at the same time as everybody else.
Well, in principle, the old persons, the elders are the first before the workers. But when you get in a place with a nursing home, you vaccinate everybody at the same time, okay? Because you're there and they are there, the workers. So it's the kind of as if they are at the same level. But if you have to choose, you choose always the first priority. But you manage that with your community at the best you can.
So there's still a question that I didn't get an answer to, and that is, will they have to wait until March 15, or are they going to be in the next round of vaccines that are coming in for our Elders Home?
This I don't know. It
Okay.
depends on when the dose come, and
Right.
there are so many unknown. I
Okay.
cannot
Thank
answer.
you.
Sorry.
We have a
Thank you.
question from Grand Chief Simon.
Yeah, there was one. There was a question that had been floating around since the early days of the pandemic, was the transmission between pets and their owners, and what adverse effects I guess it would have on the pet as well, and how would they treat the pet if that's the case.
Yeah, there was transmission demonstrated in particularly cats and tigers and lions and zoos. Okay, but this is and you would not have a cure for them, not a medication. If we don't have medication for humans, we didn't develop medication for cats or pets. So, but the cats were not so sick, but some of them had kind of flu, the sniffing and coughing, and they could transmit the COVID to their human counterparts, but probably they got it from the human instead of the reverse. And it's not an epidemiological problem. You know, the cats will not start to get COVID and transmit it to humans. It's those pets were unlucky and got it from their human masters, and not the reverse.
Yeah, because I'm not going to swap the cat.
Sorry, it's got.
All right, sorry about that. We're just making having a little bit of fun over here at the same time. Dr. Grenier, we have a question. How many times can a person contract the virus? I think you've already answered that in saying that we don't know at this point. But do the symptoms get worse if you contract the virus? Do they get worse? They seem to be worse the second or third time.
Well, what I've seen is about the same, but there are not so much studies about that. What I read is about the same, not worse, not less, about the same.
All right, thank you very much. We have a question here. I actually have a couple of questions, and I apologize. This is not really for you. However, I think it has to be answered. One of the questions is the vaccine in Kanesatake only for people who live on territory, or for all band members? We were actually taking, thank you very much for the question to the person who sent it. We just want to let everybody know that we've gone a step further here at the Kanesatake Emergency Response Unit and said that not only is it going to be available to community members that live on territory and off territory, but to any First Nations individual that requires it through our service. So if a person is living as a First Nations member in, for instance, St. Placide or around the area and would like to come and get the vaccine through our community, we have already addressed that, and we will be giving that vaccine to that person at the same time. We had another question here. Whether or not it's going to be administered similarly to the flu vaccine. It's all voluntary. Yes, it's going to be by appointment only. It will be highly structured, very strict in the way that we're going to do that. And that's what we're working on now. We'd like to thank the Public Health Authority, who's been giving us a lot of help with that, and giving us the expertise and the individuals that are able to help us set up not only the physical site, but also the logistics into getting the equipment and the necessary medical staff there. Joyce, I was wondering if you had any other questions, and I'll take the time also to give everybody the telephone number one last time, 438-686-4335 if you have questions, 438-686-4335. Please just give us a call and we'll be happy to get it to you. Joyce?
Okay. I'm not sure if you know, but whether you do or you don't, it's still going to be the same thing. A lot of our families are mixed, native and non-native, living together, and they have children together. If we give the vaccine to the person who's native, when we're doing our campaign, flu campaign, a vaccine, will their spouse be able to come in and get their vaccine along with them? or is it only going to be for the person that's native? Because we have a policy at our health center that we will vaccinate the whole family. We'll do the whole family. Because that's the way we are. If they live in our area and they're living on territory, we don't exclude them. We don't discriminate. There's been enough of that going on, but at the same time, because of the shortage of vaccines, I want to know. And for our teachers coming in that are from the outside, will they get vaccinated, when they're working with their children at school? So just your thoughts on that. I know there's a priority list, so that's why.
Are you asking the question to me, or because for the amount of doses that will be prioritized to First Nations, I think there will be no risk of missing some doses or having not enough. So I would argue to do as usual for the vaccines, all the family, but this is organization on your hands.
Dr. Grenier, we have a question here in regards to the different strain. Is there any difference in the efficacy of the vaccine towards the virus for the different strains that now seem to exist?
Well, it's too early to know exactly about that because those new strains are very recent. But up to now, what I know is that the vaccines are all as efficient against the new strains. The strains are not different on the immune site of the spike. So we're lucky about that. So the vaccines seems to work as well. So that's why we are in a kind of emergency to vaccinate, because if we are too late, then the very fast spreading strain could come first.
Thank you very much. Dr. Grenier, your presentation was fantastic. In fact, it took a lot of our questions out of our bank. And I think we've gone basically through it. We haven't been receiving any other calls in regards to the community. We'd like to thank you for your time. We'd like to thank you for all the energy and all the healthcare workers, for that matter, in doing what's necessary to keep the entire population safe. We really do appreciate it. On behalf of the Mohawk community of Kanesatake, we would like to thank you as well for coming here today with Madame Terry.
It was a pleasure.
And talking to us and letting us know how things are and where things are. Again, we prefer to get the information from, if you will, hold on, I'm sorry, we got another question coming in. So said last right under the wire. Will there be any restrictions put in place, doctor, if a person does not get the vaccine?
You mean we would be different treatment between vaccinated versus unvaccinated people?
Yeah, we're hearing stories from across the globe where people are saying that certain would not allow people get onto the airplane.
Yeah. Getting on the airplane or going to being able to get in a country. In Canada, I'm not a politician, those are kind of rather politic decisions. But I hope not, because we should work on a populational basis. The more people vaccinated, the less the COVID will circulate, and it protects everybody at the same time. So because some people, for instance, if I am allergic with anaphylaxis after my first dose, or because even without a dose, and I cannot be vaccinated, I won't be able to have a trip or to go some. That's not logical. That's not ethical. Okay, so we have to have programs. We offer the vaccine to the more people as possible, but we don't discriminate people if you are vaccinated or not. That's my opinion, but I don't know what the politics will choose to do.
All right. We had another, actually, two or three more questions. I apologize. I thought we were at the end. And we were historically in our community, we see that people usually get vaccinated in the percentage of approximately 30%. And maybe Joyce can correct me if I'm wrong, but that's what we saw in the H1N1 campaign. Now, what our question was to obtain herd immunity. What is the percentage of the population that we're looking at hopefully vaccinating?
Well, we need a lot because COVID is quite contagious. The more contagious is a virus, the more immunized people you need. Like measles is one of the most contagious disease, and you need to have 95% of coverage to stop the measles. And I guess COVID is quite contagious. So the best, the most is the best. That's clear.
So in other words, we're looking at from the public health sector. You're saying that we should be looking at
90%, 95%.
Okay.
This is the objective.
Thank you very much, Doctor. Again, we appreciate the time that you spent with us here today, and the fact that we're getting the word from the people who know about the situation, how things work. We really do appreciate it. We would like to invite all community members who have listened to kind of show appreciation to Dr. Grenier, if you will, on his behalf. I'm going to ask for something. If you could go out and spread the word. There's a lot of false news that's coming across on social media and other places, and word of mouth, it's not necessarily true. You've heard the truth here tonight. You've heard the way things work. You've heard the setup that Dr. Grenier and his team have done, and we know a little bit more now. So we're going to ask the community to get involved. Not everybody in the community was listening to our broadcast tonight. We appreciate that. We understand that there's always constraints, not necessarily able to do it. But if you would, on behalf of the people that are here, we would ask that you please do that. Talk to your family, talk to your friends, talk to your neighbors and the like, and encourage them to at least ask the questions. Ask the questions and look for the answers from valid sources like Dr. Grenier, like his staff, like his team, and don't necessarily, because it came across on a Facebook page, believe that it's the God's truth. We really want to express that to the entire population. A lot of myths were dispelled here today. Dr. Grenier took the time to do that. We really do appreciate it, Dr. Grenier. I will leave the closing words, sir, to you. If you would, please, if you had any suggestions, any advice for the community.
Well, first of all, thank you, everybody, to be there. And I do appreciate your talk to everybody around you about what we learned tonight. That's the best ending I could imagine.
Thank you very much, Dr. Grenier. Madame Thériault, Grand Chief Simon, Joyce, everybody going to slugger down. So, thank you very much. Merci beaucoup tout le monde. I hope you enjoyed our show this evening. We will be keeping this on the Facebook pages so that you'll be able to watch it again at a later date if you so desire. If you have any questions, you can also email us here. All the questions were written down, all the answers rather were written down. Email us info@keru.ca. That's info@keru.ca. And we will gladly send you the information that was given by Dr. Grenier and his team here today. So thank you very much, everyone. Have a great evening, and please stay safe.